This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from Neurosurgical Review, published in 2026, titled Results of TcMEP-Guided Vestibular Schwannoma Surgery, Long-Term Follow-Up and Progression-Free Survival.
This is a topic that hits home for anyone who spends time in the posterior fossa. We're talking about Coos Grade 4 vestibular schwannomas, those large tumors that aren't just sitting in the CPA, but are actively compressing the brainstem or cerebellum.
Exactly. And as we know, the surgical philosophy for these has shifted dramatically over the last few decades. We've moved away from the gross total resection at all costs mentality toward a functional preservation model. But the big question has always been, if we leave a little bit of tumor behind to save the facial nerve, are we just setting the patient up for a massive recurrence 5 or 10 years down the line?
That's the sword of Damocles hanging over every subtotal resection. This study out of Radboud University in the Netherlands really tries to quantify that risk using intraoperative neuromonitoring, specifically TcMEP, transcranial motor evoked potentials. Alara, walk us through their cohort and what they were actually measuring.
So they looked at 55 patients surgically treated between 2015 and 2024. These were all Coos Grade 4. They used a standard retrosigmoid approach under total intravenous anesthesia. The key here was their use of the threshold level method for TcMEP.
For the residents listening, let's pause there. Most of us are used to this super maximal method where you look for a percentage drop in amplitude. What were they doing differently?
They were looking at the intensity of the stimulation needed to elicit a response. They established a baseline, the minimum milliamps MA required to get a MEP from the facial muscles. During the resection, if they had to increase that stimulation by more than 20 milliamps to get a response, that was their stop signal.
The 20 MA rule. It's a very binary, actionable threshold in the heat of surgery. If the nerve is getting unhappy, the threshold to fire it goes up. If it jumps 20 MA, you stop resecting that interface, even if there's tumor left.
And the results seem to justify that caution. They found that a threshold increase of less than 20 milliamps was a strong predictor of good functional outcomes. Specifically, at the 1-year mark, 83% of their patients had good facial nerve function. That's House-Brackman 1 or 2.
That's impressive for Coos 4 tumors. Usually, when we see these massive tumors, we warn patients about a significant risk of permanent palsy. But look at their immediate postoperative numbers. 58% of patients had a decline in function right after surgery.
Right, but the long-term follow-up is the kicker. By 1 year, the vast majority had recovered. It shows that the TcMEP-guided approach protects the integrity of the nerve, even if there's some temporary neuropraxia from the manipulation.
Okay, so we've saved the nerve. Now let's talk about the price we paid. How much tumor was left behind?
In 84% of the cases, 47 out of 55 patients, they had a residual tumor. Now, they categorize these into near total resection, NTR, where the remnant is less than 5% or just a smear on the nerve, and subtotal resection, STR, which is anything more than that. The mean volume of the remnant was actually quite small, only 0.4 cc.
0.4 cc. That's a tiny fragment. But to a neurosurgeon, any remnant is a potential recurrence. What did their long-term follow-up show regarding progression-free survival?
This is where the 2026 data gets really interesting, because they have an extended follow-up. For the near total resection group, the median growth-free survival wasn't even reached. For the subtotal group, the larger remnants, the median growth-free survival was 76 months. That's over 6 years.
And if you look at the Kaplan-Meier curves in the paper, fewer than half of the residual tumors showed growth within an 8-year window. That's a huge data point for our clinical decision-making.
It really challenges the reflex to send these patients straight to gamma knife or fractionated radiation therapy the moment we see a remnant on the 3-month post-op MRI.
Exactly. In the past, many centers would say, "We left a piece, let's radiate it now to prevent growth." But this study suggests a watchful waiting strategy is actually more appropriate. Why expose a patient to the risks of radiation, like secondary malignancy or even delayed facial nerve or hearing loss, if more than 50% of those remnants are going to stay quiescent for nearly a decade?
There's also the surgical nuance. Dr. Eris, when you're in there and the TcMEP threshold starts to climb, do you find it difficult to stop?
It's the hardest thing in neurosurgery, the exit strategy. Your ego wants that clean post-op MRI with no enhancement, but the TcMEP gives you an objective, data-driven reason to pull back. This paper reinforces that if you stay within that 20 MA delta, you're likely leaving a stable remnant.
They also mentioned that the growth of the remnant, when it did happen, was often slow. It wasn't an overnight explosion of tumor. It gives you time to react.
Let's talk about the limitations for a second. It's a retrospective study, and 55 patients is a solid number for a single center, but it's not a multi-center trial.
True. And they noted that the definition of NTR versus STR can be a bit subjective, even with volumetrics. But the core message, the correlation between the 20 MA TcMEP shift and the HB score, is very robust.
If you're a resident preparing for boards or a case tomorrow, what's the pearl here?
I'd say the pearl is TcMEP is not just a monitor, it's a guide for the extent of resection. A threshold increase of less than 20 MA is your safety zone for facial nerve preservation. And if you have to leave a small remnant to stay in that zone, the long-term recurrence risk is lower than you might fear.
And for the attendings, the takeaway is the management of the postoperative remnant. We don't need to rush to the linear accelerator. We can follow these with serial MRIs. 76 months of median PFS for subtotal resections is a long time.
It's about the quality of life. An HB grade 2 at 76 months is much better for a patient than an HB grade 4 with a clean MRI.
Well said. This study from Gorissen et al. Really helps codify what many of us have felt intuitively. The facial nerve is the priority, and the biology of these small remnants is often more indolent than we assume.
It's a great leap forward in personalizing CPA surgery.
That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode. End of dialogue.